Ladies and gentlemen, it is my great pleasure and exciting to share a story of HIV stigma reduction in health facility in Thailand in a virtual context. First of all, I would like to say apologies for my English skill, and I do hope that you will understand story that I will tell you in a minute. My story is going to be a journey of taking part as a community representative in development of HIV stigma-free in health facility model in Thailand. So please allow me to move to the next slide. From the perspective of civil society, Thailand's journey to the national response to stigma and discrimination started in 2009 with the Stigma Index. The Stigma Index is a process of which the LHIV design the study, collect data, analyze it. This process is critical to build up capacity within the community and to allow the community to speak out about stigma and discrimination. In Thailand, this brought stigma into the spotlight and catalyzed collective action. Because of the data demonstration is tangible ways how stigma discrimination was occurring, provide evidence for advocacy, and brought civil society and government together to examine the situation that even with universal access to ARV, its dates were still high and people are getting on treatment late. So with the evidence of the high levels of stigma from the Stigma Index and the epidemiology data, civil society and the government came together to look for a way forward to change the situation. This slide shows Thailand's journey to develop and implement a national response to measure and tackle HIV-related stigma and discrimination. I'm not going to focus on the detail, just to show the progress we have made and our journey to date. The detail of this process are available in the forthcoming article in the journal AIDS. What I want to focus on is to say that the Stigma Index shows that stigma is happening in many dimensions of life, family, community, work, healthcare, education. There was much discussion about where to start. In the end, the data from the health facility collected in 2012 to 13 demonstrate that stigma was high in health facility, and it was decided to start there. I will now focus on the process for developing intervention in health facility to address stigma and some lesson learned to think about when scaling up to national levels. We developed the 3x4 approach, which is a comprehensive stigma and discrimination reduction package for health facility. It addresses 4 key actionable drivers: awareness, fear, attitude, and facility environment in 3 levels of intervention: individual, facility system, and community linkages. Based on global best practice, this slide shows the 3x4 approach which we use to approach the hospital, participate in a pilot program to scale up period. I don't have time to share detail on all of the pieces, so let me focus on curriculum development and practice. Thailand participatory training curriculum adapted from global toolkit with series of stakeholder workshops supported by international technical assistance. There are a number of PLHIV, key population, local and international NGOs, development partner and government representative meet together, start with 21 exercise, finalize into 10 activities, fit into 2 days training program in health facility and test in 1 facility. Followed by national TOT for 3 trainers team and planning to implement in 6 district hospitals in 3 pilot provinces. The final curriculum, this slide shows the final curriculum of pilot phase and scale up phase. The curriculum of pilot phase has 10 activities. 9 activities were adapted from global toolkits with 1 additional country activity, which is activity number 8, the self-reflection. This activity will allow participants to think carefully for what are those stigma and discrimination that they committed to change by their own self, and what are those that they need other colleagues together for changing. This is country standard curriculum. For scale up, the curriculum was shortened to 5 activities, which try to capture all 4 key drivers of stigma and discrimination in health facility and the solution within one-day training. The training implementation of stigma and discrimination curriculum in the pilot phase is different from the scaling up phase in a few ways, such as the trainer team of pilot phase, including both member focus from healthcare worker and civil society, who were selected with expectation to become mass provincial trainer team, and is decided as a mechanism to work in collaboration with hospital champion team, while the trainer team at scale-up phase have only healthcare workers from hospital. The training courses of pilot phase is 2 days, while the scale-up phase is 1 day. For the lesson learned, though I am very proud of progress that Thailand has made in our scale-up from 2016 to 19. In total, we can scale up to 110 hospitals, both large and smaller hospitals in 71 provinces out of 77. However, for learning for other countries that may want to follow up, I want to share some challenges that we face with our scale up from my point of view. There is always pressure to move quickly to large numbers. Some key challenges that I would like to mention here are: 1. Burden increase in champion team at hospital to manage with 3 new contents: the stigma and discrimination survey, the participatory training, and the quality improvement activity. Most of the hospital focus on the training sessions and left out linkages activity with communities. The lack of voice of PLHIV and key population as trainer and as well as participant in the training session. And also the 5-day training of trainer for 3 new contents is tight and pressure. The shortened version of stigma and discrimination curriculum is used without testing. Coaching were changed from hospital base in each province to regional base due to limited resources and coaching staff. These challenges are reflected from pre and post results of pilot that's stronger than scale up among 48 hospitals in the first scale up phase. In conclusion, stigma-free in health facility progress in Thailand from pilot to scale up and to national rollout initiative is show a good signal of change while confronted with challenges. On the move to reduce stigma and discrimination, to ensure access, engage, and retain in healthcare, we found that some hospitals taken out discrimination of spreading bed for HIV pregnant women in delivery room, while some still not change. Some stop arranging HIV positive clients to last queue in dental clinic, while some still not change. Some let HIV positive women make their own decision in pregnancy, while some still encourage them to terminate their pregnancy. All these change need time, but does not mean let time pass. In Thai socio-cultural context, there is one core concept of living together, which is called Jai Khao, Jai Rao, or care for other people's mind as well as your mind. Many health staff mention things they have learned while keep listening to PLHIV during participatory training, that if I know that what I did caused a lot of impact to you, and it was stigma and discrimination, then I will stop and do it in another way. 2 hospital directors from pilot phase said that HIV stigma reduction in hospital are process of Jai Khao, Jai Rao. And another one said that is a process of changing mindset of healthcare to client centers. For 3x4 approach, community engagement is an important and challenges on moving forward to our goal, stigma-free in health facility. This is mean MOPH need to bring this intervention back. Thank you for your kind attention. Thank you for all partners whom joined this journey together. Thank you, Roland Ibret, chairperson of this session, for your reflection on my presentation. And thank you for the organizer for inviting me to speak on this session. Lastly, I would like to dedicate this presentation to my friend, Noi, Ms. Amnoy Salim, a member of the National Trainer Corps teams, who has had heart of gold in HIV stigma and discrimination reduction. Noi passed away last year. Thank you.